All right, welcome to Three Plastic Surgeons and a Fourth. My name is Dr. Lawrence Tong. I am joined, as always, by my esteemed colleagues, Dr. Sam Jejurikar, Dr. Sal Pacella, and Dr. Sam Rhee. Their Instagram handles are at Sam Jejurikar for Dr. Sam Jejurikar, at San Diego Plastic Surgeon for Dr. Pacella, and at Bergen Cosmetic for Dr. Sam Rhee. My name is Lawrence Tong at Yorkville Plastic Surgery. And today our topic is going to be about a recent statement that came out from the breast surgery collaborative community. And they are a group of plastic surgeons and breast surgeons who came out with some terminology and recommendations for how we talk about something called capsulectomy. So I'll just start off with talking. Actually, Dr. Rhee wants to say something.
Yeah, let's go with the disclaimer really quickly.
Yes, sorry about that.
No problem. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based on the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show.
All right, thank you very much. So the statement had to do with terminology regarding capsulectomy. So in general, what is capsulectomy? Capsulectomy is an operation that is done to remove breast implant capsules. Now, breast implant capsules can happen for a variety of reasons, but it's basically a scar that forms around a breast implant. So they put this out because there's a lot of different terms that were used previously, and they want to sort of make everything consistent. So the 4 types of capsulectomy they came out was as follows. And I like to think of it as...
Before you get into that, LT, why is there so much controversy about capsulectomy? I think that's probably something we should touch upon, right? Like, why has this become such a hot topic? It's not the operation in of itself, it's some of the diagnoses that we're seeing and some of the controversial things. One of the things that you had mentioned was that there were plastic surgeons, breast surgeons, but I think there were also patient advocates on this consortium as well. And I think it had a lot to do with breast implant illness and also with breast implant-associated lymphoma. And there's a lot of controversy among patients and a lot of controversy among plastic surgeons about whether or not these things are, what operations are actually required in what circumstances. And so I think that's why this terminology actually, came about. I think for patients that might be listening to this podcast, the reason they potentially want to hear about this is if they think they might have breast implant illness or they're worried about it, this terminology can be pretty helpful to help figure out what you need. So sorry to interrupt. Keep going.
No problem. So the terminology that they have come up with was 4 different types of operations, and they have named it as follows. Number 1 is on-block capsulectomy. That means that the implant and the capsule with some surrounding normal tissue is removed. So that's an operation that is removing the whole thing intact with some normal tissue, a rim of normal tissue around it as well. The next category is total intact capsulectomy, which means the surgery involves removing the implant plus the capsule in one piece. The next category is total capsulectomy. That's the whole thing, but not necessarily as one piece, and it can be removed in multiple pieces. And then the last category is partial capsulectomy, which means that the capsule is removed, but some of it is left behind. So, the reason why Dr. Jejurikar said that there was controversy about this is because what we've seen is that we have, and you guys have probably experienced it, have patients come in and they're concerned that they have something like breast implant illness, and they instantly come in wanting to have on-block capsulectomy. What's your experience with, those types of patients?
I think breast implant illness is a topic that is very much so a very hot topic among patients and among plastic surgeons, and it is generally some divergence of opinion among the plastic surgery community versus many patients that are out there. Just to be clear, breast implant illness is the only diagnosis that I know of. Maybe you guys can think of other things where it was actually a diagnosis that I think patients came up with, basically based off of many different symptoms, whether it's fatigue, hair loss, changes in nail growth, muscle aches, joint pain, stuff like that, where when you look at the symptoms that can make up breast implant illness, there's, I think, more than 100 symptoms at this point that can be classified underneath it. There's tens of hundreds of thousands of women that are out there that think their implants have caused these symptoms. So you don't want to be, don't want to be dismissive of these large groups of people that are experiencing problems. But the plastic surgery community has really tried to look into whether or not there's any direct linkage between implants and these symptoms that are out there. The patients that come in that say that they have these symptoms, a lot of times what some surgeons are pushing is an aggressive operation, which is called an en-bloc capsulectomy. And it's important because en-bloc capsulectomy, the way most surgeons have defined it, is different than the definition that Dr. Tong has just defined. The way most surgeons typically define it is removing the implant and the capsule in continuity with each other, but not necessarily taking a rim of surrounding tissue. The rim of surrounding tissue is typically something that you would reserve for a cancer sort of diagnosis. But that's what surgeons typically will talk about. And to be clear, an en-bloc capsulectomy is not just a difficult technical endeavor, but there's real risk that goes along with it. You can injure the skin flaps along the front portion of the capsule, and even more importantly, posteriorly, and if the implant's behind the muscle, there's a real potential to actually get into the thoracic cavity and cause issues with the lungs and whatnot. So, the question is whether or not total capsule removal is required, whether or not en-bloc or, removal of the capsule in continuity is required. I'll say that I tell people that I'm not sure why taking out a rim of normal tissue would ever be indicated. If they feel strongly that the entire capsule comes out, I'll do my best to do that. I can't guarantee I can do it in continuity with the implant in some really severe cases as well. But we'll do it. I don't know if it has, if it's medically necessary. I tend to believe that it's not.
I'd like to back up just a little bit because I think if you are not someone who has breast implants or you're maybe considering them, you might think this sounds really scary. So we're talking about breast implant illness. We're talking about capsulectomies. We're talking about all these sort of issues that can happen after breast augmentation with that implants. And these are issues that I also have my thoughts about, but I also want to point out that these are relatively uncommon complications. So as we talked about, capsular contractures, formation of scar tissue around an implant. And in most cases, this is a relatively asymptomatic, normal occurrence. I mean, maybe 1 in 6 patients might have some capsular contracture. And out of those, most of them don't really have any issues. And as plastic surgeons, we've classified capsular contracture, which is the scar tissue that forms around an implant. And, usually the grades go from 1 to 4. Grade 1 is almost not visible. You can't see it. It feels very natural. There's no symptoms. Grade 2 is very minor, maybe slightly firm to the touch, the breast, but usually normal in shape. It's usually with grade 3 or 4 that patients start having more concerns about capsular contraction. That's where the breast will be very firm or appear tight appearing, or the shape has changed to some degree. And with grade 4, you can have soreness or tenderness or pain associated with the capsular contracture. And again, this is there are a lot of factors that go into why people develop capsular contracture. We as plastic surgeons know what some of these factors are. Some of it's genetic, some of it is the environmental circumstance in which the implant is placed. And for a lot of us, we are fanatic. We are obsessive about avoiding capsular contracture, and most surgeons who place breast implant are very familiar and engage a lot of techniques to minimize the risk of capsular contracture. But as we have talked about, there are some complications such as potentially breast implant illness or severe capsular contracture where treatment is indicated. And this consortium is really helping to define some of those terms, helping patients understand what the different possibilities in terms of treatment are. And as Sam has said, it also helps patients and surgeons come together for a common terminology so that we can express our opinions about what we think is most helpful for patients.
So this has been a very hot topic in aesthetic surgery research over the last several years. So I sit on the board of directors of an organization called the Aesthetic Society Education and Research Foundation. It is the research foundation that's associated with our main cosmetic surgery society, the Aesthetic Society. There's a series of papers that came out over the last 2 to 3 years by two authors, McGuire and Glicksman. And it looked at the various indications for capsulectomy. So they took a group of patients and they described their symptoms. So some had this breast implant associated illness type of symptomatology. And then they did a huge analysis comparing the type of capsulectomy on their symptom impact. And the study was very insightful. It was a validated study. It had great power. And they found zero difference in the type of capsulectomy performed in the impact on patients. So in other words, patients' symptoms improved with removal of the implant, partial capsulectomy, total capsulectomy, or en bloc capsulectomy, exactly the same. So this is a scientific paper that sort of demonstrates that the type of capsulectomy is not necessarily important. It's the presence of doing a capsulectomy and the implant removal that's important on improving symptoms.
Yeah, and the other thing they looked at too was they looked at certain enzymes, metalloproteases in the capsules as well, which has been thought to be linked to breast implant illness. And they actually found that when they looked at every capsule that had been sent in patients that reported breast implant illness, they couldn't actually find any of this. And so it even raises the question whether a capsulectomy at all is required for patients that have this. But yeah, that being said, so, the question ultimately that many patients that are primary breast augmentation patients that are coming to see me for a consultation will ask me this question: do you think that there's a high probability that I could get breast implant illness? What do you think, what do you think is the likelihood that I could get it? Do you even think it's real? How do you guys answer that question?
Well, I'll say that. Yeah, go ahead, Sam.
Okay. So I sort of go over the original data that we found for textured devices, right? And so we know from looking at the data of indications of of large cell lymphoma. So lymphoma or breast implant, not breast implant illness, but lymphoma. Okay. That's something we have a validated understanding of. The risk associated with textured devices of developing breast implant associated lymphoma is about 1 in 2,900. Okay. And there's a massive proportion of these that were from one company with one type of texturing. It's called the biocell texturing, aggressive texturing. It was made basically by dousing the implant in salt and creating this sort of textured granular surface. If you look at systematically the other companies that had textured devices, the way they make their texture was imprinted mechanically. Very low rate of textured devices. In smooth devices, the risk of breast implant associated lymphoma is essentially negligible. Okay. And in patients who developed breast implant associated lymphoma that had smooth implants, 99% of the time they previously had a textured device in. So to me, the lesson is clear. We use smooth devices, right? And so I tell patients, I only use one company, not the company that was associated with breast implant associated lymphoma. I use a smooth capsule, and then usually, the fear is usually dissipated after that. So I don't know what you guys do.
That's a great answer, but that's a different question though altogether, right? I mean, I think that's about lymphoma. breast implant illness is the one that I think is so much more controversial, because there are some surgeons that are out there that say it does not exist. And there are other surgeons who make an entire practice out of doing en bloc capsulectomy on patients. They have entire practices doing en bloc capsulectomies for patients who have breast implant illness. So how do you answer the breast implant illness question, Dr. Pacella?
Well, let me sort of tether that. So when I bring up the concept of the general question is, do breast implants cause problems? Okay. So we know that it causes one problem, breast implant-associated lymphoma. Okay. We know that there's possibly some connection between another problem, breast implant illness. Okay. And so I say, well, this is the data for the problem that we know about. Okay. The other problem is something that we can't necessarily put our finger on. Now, that doesn't necessarily mean that there's not a connection. There's some intermediate factor between the presence of getting implants and the development of breast implant association or breast implant illness. But there's nothing in the literature, there's nothing in a study that shows that there's any cause, effect, or complication related to that. And in fact, I also bring up the statement, arguably no other medical device in the history of humankind has been studied more extensively than than silicone breast implants, from the Dow Corning scare in the 1980s.
Yeah, I'll just
So
bring up one thing that's important. We've been talking about capsular contracture, breast implant-associated lymphoma, and breast implant illness as sort of on the even plane. But the fact is that there is no universally accepted medical definition of what breast implant illness is, and it's not a recognized distinct medical condition. That's not to say that women don't have these symptoms, and that's not to say that there may not be an association with the breast implant for causing this, but as of yet, it is not a recognized distinct medical condition. And as stated before, it's controversial because the symptoms vary so much: fatigue, brain fog, joint pain, autoimmune-like symptoms, and the mechanism, a physiologic mechanism to link breast implants to some of these things is very, very difficult. And the research, as has been pointed out earlier, it's not conclusive. There's nothing to show that there's anything special between at least the pathology in the capsules between breast implant illness and somebody who has no symptoms at all. And I think that it's further propagated because online there are communities where patients share their experiences, and this may potentially lead to validation of symptoms that other people may have because they'll latch onto it. So there is definitely some skepticism by healthcare providers, and I think that's healthy. We shouldn't just accept that what a lot of people say is maybe true without research, and further research is definitely required. But I just wanted to make the point that as of yet, it's not a recognized medical diagnosis.
I'll say this: when I talk to patients about this, especially when they're concerned about any risks associated with breast implants, I will say, in my experience, I've done hundreds of breast augmentations, and I might have seen one or two possible breast implant related illness cases, and I wasn't sure at all. Having read the reports and seeing what's out there, I don't discount that there is a BII, a breast implant associated illness. There may very well be. The issue is that if it does occur, it's pretty rare, and it's really hard to study rare conditions. And as Sal said, you need a lot of power. You need numbers in order to be able to tease out the facts with this. And we just haven't had those numbers yet, or the types of studies that can tease that out. I will never discount anybody's personal experience. And certainly I've had patients, both mine or others, who have come to me, and for whatever reason, they would like to have their implants removed, and they would, with or without a capsulectomy. And I will never say never. Like there are plastic surgeons who will absolutely refuse to do that, if especially if they come with issues that are vague or what they feel is unsubstantiated. And I think that's wrong. I think a patient can choose certainly to do what they want to do. I think the issue really is that when they come with whatever experiences that they've had and they're asking for some of these procedures, you have to let them know, I know you've read about en-bloc capsulectomy, but this could actually be detrimental to your health in a way that you hadn't anticipated. And this consortium has said an en-bloc capsulectomy, where you're taking out healthy tissue in addition to the complete capsule removal, is really only indicated for cancer. It's not indicated for BII or any other condition. And so this gives us, again, a base to talk to patients about. Now, the issue really is that when some of these patients come in and they have very strong ideas about the type of procedure that they want because they've talked to others, how do you deal with that? And I'd be interested in hearing, like, because some of it is really about their beliefs and respecting that to a certain degree.
I think I agree with everything you just said there, Sam. That's basically my approach as well. I think when you have capsular contracture, which we know is an inflammatory condition, and then you have patients that have autoimmune diseases, it's not hard to extrapolate that there could be a few patients where they could get a systemic effect from this local inflammatory reaction. So then how do I handle someone that comes in and says that they want their implant out? I will say that I think this consortium has been really helpful, because the terminology now is that I'm not going to use the terminology en-bloc capsulectomy, but instead we'll talk about a capsulectomy in continuity with their implant. If in some cases, you guys know this as surgeons, sometimes it's really kind of easy. Like, you'll start doing the dissection and it's pretty easy to get it out and to do, to take out the entire capsule in continuity with the implant. Pretty easy, comes off from the soft tissue, and if I can do it,
subglandular, it's like,
yeah,
pretty easy.
Subglandular, or maybe a saline implant that doesn't have as thick of a capsule as a silicone implant. Sometimes it isn't easy, and where it's difficult is when you're doing an implant that's behind the muscle, stuck to the chest wall. Visualization might be a little bit difficult. So, if someone says that I insist on getting my entire capsule out, I will tell them I will do my best to get it in continuity with the implant. I will do my best to get it off the chest wall. But if we're in a situation where the implant is stuck to the chest wall and I feel really uncomfortable that I might do more harm than good, there's no data to support me doing that. And I can't look you in the eye and tell you that I can guarantee that the entire capsule will come out. I will do my best, but I can't guarantee it. And I've lost patients because of that, because there are other surgeons that'll say that they'll get it out and that it's medically necessary. But I think the data is conclusive that that's just not true.
One of the other statements that was interesting that they've just made is that capsulectomy does not guarantee that a patient can't develop breast implant-associated lymphoma. So the other recommendation that they make is that even if somebody has had a capsulectomy, they should continue to monitor the breast for symptoms of cancer in the future.
I've gone back in post capsulectomy implant removal in a few patients when years later they've decided to go back and have implants placed. And it's surprising how rapidly the body heals. I mean, even in patients who had relatively thick capsules, that scar tissue really resolves well. And so I don't feel like I'm leaving a time bomb or that there's some major issue from doing a partial capsulectomy, or if there's some areas that are difficult technically or may put the patient at risk. I have seen firsthand, I've seen these capsules, they resolve, they heal. And universally, I think you are right. Once the implant is removed, once you've done whatever capsulectomy you feel is appropriate, patients feel better. Their symptoms resolve well. I have never, I don't want to say never, but I don't think I've ever seen a patient really where they continue to have whatever issues they had, regardless of the type of capsulectomy that was performed.
You're talking about BII, right?
Yes.
Yep.
Well, Sam, I sort of have witnessed the opposite. I think, I would say that, being in practice for close to 15 years, I've probably had 30 patients come in to see me that were convinced that their implants were causing brain fog, fatigue, etc. fibromyalgia. They've taken them out. We've taken them all out. We've given them the benefit of the doubt, did as much of a capsulectomy as we can. And I can't recall any patients saying that their symptoms improved, systemic symptoms.
Oh.
Yeah. I have not seen it personally. And I share that information with patients who come in.
Yeah, I think that's
I can't say I agree with Pacella on that. I've probably had a dozen patients who like you guys, I've seen like more than 100 patients come in with self-reported BII, more often than not as capsular contracture. Implants are too big, causing mechanical issues. But there's been at least a dozen who have said that they had sort of vague BII symptoms. And my experience has been that in at least half of them, in a delayed manner, maybe several months after the fact, they began to experience improvement in their symptoms. So I can't say that I'm more convinced than not that it's a real phenomena.
Well, I tell patients that I'm going to be doing this operation on is that A, I can't guarantee that I can remove it in one piece if that's what they're looking for. And more importantly, B, I can't guarantee that their symptoms are going to change at all. So I think that's fair because, a lot of times I think patients get relief maybe because they're so focused on getting that implant out that just having it out psychologically makes them feel better. I think there is a good proportion of patients where that effect does occur. But whatever the mechanism for them to have their symptoms relieved, that's good. And I think that the fact that with Glicksman's research showing that capsulectomy, whether it's partial, whether it's intact, whatever type it was, all showed good improvement in symptomatology is, confirms that or backs that up at least.
I like what the consortium said. They said it's always a patient's choice to elect to undergo a procedure such as a capsulectomy, provided the risks are clearly understood. But it's our responsibility as plastic surgeons to ensure that patients get the best evidence-based information. And right now, a lot of patients are given a lot of misinformation on internet and social sites. And so it is incumbent on us to talk to our patients. We have our own data that we've seen personally as surgeons, but there's also a lot of data out there where, as Sal has said, as Larry has said, as Sam has said, where, there's still a lot that we don't know. And it is tough for patients to navigate, especially when they're on TikTok or Instagram and they're seeing someone relate a single experience, which could be very different than what most people have. I mean, even amongst us four surgeons, we're having some variation in terms of our own experiences, in terms of what we see. So I can only imagine how different other patients' experiences can be if you just look at it one at a time.
All right. Any last words to add from any of our panel here? All right, that's good. This is a very interesting topic. I'm sure that we'll be revisiting it in the future. Once again, thanks everybody for watching, and thank you for my esteemed colleagues, and we will see you the next time.